Good morning all. Today's our topic is drugs for the bronchial asthma. Now, bronchial asthma is characterized by the hyper responsiveness of the tracheobronchial smooth muscle to a variety of stimuli and resulting in narrowing of the air tubes, often accompanied by increased secretion, mucosal edema, and mucus plugging symptoms, including dyspnea, wheezing, cough, and maybe limitation of the activity. Asthma is known recognized to be primarily inflammatory condition. Inflammation underlying hyperreactivity and allergic basis can be demonstrated in many adults and higher percentage of the uh, pediatric patient. In other, a variety of the trigger factors due to the infection, irritant, pollution, exercise, exposure to the cold air, and psychogenic may be involved. Extrinsic asthma is a mostly episode, um, less prone to the status asthmaticus. Now, intrinsic asthma it tends to the um, perennial status asthmaticus in is more common. Mast cell and inflammatory cells uh, recruited as a result of the initial reactions produce a um, multitude of mediated by the following process. Release of the mediator stores in granules, histamine, protease, and enzyme TNF alpha. The release of the phospholipids comes cells membrane followed by the mediator synthesis, the PGs, LDs, and PFA. Activations of the genes followed by the protein synthesis, interleukins, TNF alpha. These mediators together constrict the bronchial smooth muscle, causing mucosal edema, hyperemia, and produce viscid secretion, all resulting in the irreversible airway obstruction. Now, chronic obstructive pulmonary disease is also and the inflammatory disease of the uh, lung characterized by the progressive emphysema. It is a loss of the bronchial elasticity, leads to the closure of the smaller air tubes during expiration. The airway obstruction is the essential during the exercise, uh, causing stimulate of the breath, shortness of the breath, and the uh, expirations of airway limitation does not fluctuates markedly. Now, approach of the treatment. Prevention of the AG-AB reaction. Avoidance of the antigen. Hyposynthesis possible in the extrinsic asthma and if antigen can be identified. Neutralization of IgE and uh, reading amylizomab and suppression of inflammations and bronchial hyperreactivity. Now, prevention of the release of mediator mast cell stabilizer. First one is corticosteroid and antagonism of the release mediators, leukotrienes, antagonistic, antihistaminic. Now, we are discussing here the six blockers, constrictions, neurotransmitters, anticholinergic, mimicking dilators, neurotransmitter, sympathomimetics, and directly acting bronchodilators, methoxsone 9. Now, classification. Bronchodilators, beta 2 sympathomimetic salbutamol, methylhexanthines, theophenylane, and uh, aminophenylane like drugs. Now, anticholinergic, apratropine bromide and tetrabromide bromide. Leukotrienes, analgesic, mentoleuketas, and Zephyr mast cell stabilizers, sodium chromoglycates, corticosteroids, systemic hydrocortisone, and prednisolone, and others. Inhalations, uh, beclomethasone, and dipropiopris, and budesonide, anti-IgE antibody, MIG Mumbai. Now sympathomimetics. Adrenergic drugs causes bronchodilators through beta 2 receptor stimulation. Increased CAMP formulation in bronchial muscle cell. Relaxation in addition. Release CAMP is mast cell and other inflammatory cells. Decreases mediator release. Since beta 2 receptors on inflammatory cells desensitize quickly. Now obstruction burdens should be used continuously in the hypersensitive ischemia, heart disease, and patients, and in the those receiving digitalis. Through adrenalis, beta 1, beta 2, and alpha receptor agonists, and the isoprenalins, beta 1, beta 2 agonists are effective bronchodilators. It is the selective beta 2 agonists that are now used in the asthma to minimize cardiac side effects. Salbutamol, a highly selective beta 2 agonist, cardiac side effects are less prominent, and selectively it further increased by inhaling the drug, and inhaled salbutamol uh, delivered mostly from pressurized method does dose inhaled PMDI produce broncho dilatations within the 5 minutes, and the action lasts for 2 to 4 hours. It is therefore used to avoid and terminate attacks of the asthma. It is also known as albuterol. And here the saline 2 mg tubes, 8 mg SR sustained relief tablet is also and syrup also is used for the control the symptoms. Here the inhaled salbutamol and terbutaline are currently the most popular drugs for the quick reversal or bronchospasm, but should not be used on any regular schedule. Regular use does not reduce bronchial hyperactivity. Now, bamboo terol. This uh, bis, uh, Biscarb ester prodrug of the uh, terbutaline is slowly hydrolyzed in plasma and the lungs by the pseudo uh, cholinesterase to release the active drug over 24 hours. Reversible inhibits of the pseudo cholinesterase occurs in a dose-dependent manner. It is indicated in the nocturnal and chronic asthma as a single evening dose of the 10 to 12 mg oral. Now, salmeterol. It is the first long-acting selective beta 2 uh, agonist with a slow onset of action, used by inhalation on a twice daily schedule for the maintenance therapy and for nocturnal asthma, but not for acute symptoms. It is more beta 2 selective than the salbutamol, as well as more lipophilic, which probably accounts for its longer duration of action. In concern of asthma, uh, worsening due to a regular use of the inhaled beta 2 agonist applied to the salbutamol also. Here, the COPD long-acting beta 2 agonists are superior to the shortening-acting ones and equivalent to the inhaled anticholinergic in COPD. They reduce breathlessness by preventing expiratory closure of the peripheral airway and abolishing the reversible component of the airway structure. Now Valmeter Cerovite 25 microgram per metered dose inhaler. 2 puffs BD. Severe case for puff BD. Now uh, formoterol, another long-acting selective beta-2 agonist which acts for 12 hours when inhaled is comprised to the salmeterol. It has a faster onset of action and it is used in regular morning evening schedule for the round the clock bronchodilation dose 12 to 24 microgram by inhalation twice daily. Now methyl xanthines, theophylline and its compounds have been extensively used in the asthma but are not considered first line of drug anymore. They are used more often in COPD. Theophylline is one of the three natural occurring uh, methylated xanthine alkalides: caffeine, theophylline, and theobromines. The chemical relation between the three is divided below. Here the chemical component we can see in this figure. Now they are consumed as a beverage. The source and the average alkaloid contents of the beverage as they are usually prepared are given below. Now sources alkaloids contents in beverage. Theosins T levels, caffeine aerobites and humorous cocas and cola accumulants. And there is a caffeine theory and uh, caffeine and means mostly this is the use as a beverage and mostly given with the coffee and cola tea also. All three alkaloids are equivalently similar actions but they are marked quantitatives and pharmacokinetic differences. We can see the action or caffeine is the CNS stimulation low dose. We can see in the caffeine and theanine and toxicity. Heart stimulation present, double time present, 3 time present. Blood vessels relaxation, 1 time present. Theomer, 2 time present. Bronchodilator, a single present. Here is 3 time present. Kidney diuretics, 1 time present. And caffeine, 2 time present. Theomer. Now SK muscular increase contractility, 3 time present, 2 time present. Here the gastric mucosal irritation, 1 time present, here 2 time present. And the phosphodiesterase inhibitors, 2 time present, 3 time present. Adenosine antagonism, 2 time present, 3 time present. Now caffeine means caffeine and theo means theophylline. Here the pharmacokinetic reaction on the CNS caffeine and the theonatic CNS simulations. And primary effects on the higher concentration caffeine 150 to 250 mg produce a sense of the well-being, alertness, beats, rhythms, and always fatigue, thickening, and beginning of the clearing about the dullness has tolerance.